This is Dr. Charles Parker, and you're listening to Core Brain Journal. It's a place where I connect both fresh discoveries and interesting different perspectives from advanced mind science with the realities of real people and everyday life down on Main Street. Well, welcome, folks. Here we are one more time, Dr. Charles Parker at Core Brain Journal, and this is our 058 episode. And today we're welcoming Dr. Joe Annibali up there in D.C. at Amen Clinic in D.C. Thanks for joining us, Joe.
You're very welcome, Chuck. Very welcome. Glad to be here.
We're looking forward to it. Joe has a number of interesting attributes that we're going to be talking about during this episode, not the least of which is his new book, Reclaim Your Brain, How to Calm Your Thoughts, Heal Your Mind, and Bring Your Life Under Control. That sounds like a big doggone order, but I'm sure you can do it. Go ahead, Joe. What were you going to say?
Well, no, it's a big order, but I like challenges.
You can do it. So yeah. Joe is the chief psychiatrist at Amen Clinics in Washington, D.C. He is a psychiatrist and a brain imaging expert. He is also, just found out before we started talking, a trained psychoanalyst, and he is the author of the book, Reclaim Your Brain, and he's working every day actually looking at brains. Now, it's a very interesting process. You're going to have a lot of fun listening to him talk about it. Joe, tell us a little bit about your personal self, your personal life. Fill in some blanks, if you will.
Well, Chuck, people often are tantalized or fascinated when they find out I'm a psychiatrist. There's the question, and I'm sure you've heard it a dozen times or more, why did you go into psychiatry and so forth? And I think there is something to the truism that we choose particular professions or subspecialties in medicine because they resonate with the need we have. And I think I recognized in myself when I was younger, although I wasn't quite aware of it back then, but I think I recognized in myself that there were some things I needed to address. And I think I realized that psychiatry was one way to do it. When I started medical school, I never would have thought that I would have been a psychiatrist. I actually wanted to be a plastic surgeon. Mm-hmm. And it's interesting because I think when you think about what and I always wanted to do the reconstructive surgery, not just the facelift and so forth. So I think, so more reconstructive, not cosmetic. And I think I went, if you think about reconstructive surgery, so I was thinking about helping somebody change the outside, heal the outside, mm-hmm. versus I ended up trying to help people heal the inside. But I think there was a commonality. And when I did my clinical rotations in medical school, I think in some ways I was really traumatized because the surgeons and people like that, they didn't seem to want to talk to people. They didn't seem to want to understand patients. They just wanted to do their thing. Yeah. Even back then, balance the labs and do the MRI and so forth. And I think I recognized within myself, I wanted to get to know people. I just found this, what makes people tick. And when I did my psychiatry rotation, I found that they seemed interested in people, and I think they were. Mm-hmm. And so I was a bit surprised. I remember my best friend, Dr. Gary Moak, whom you interviewed a few weeks ago. Mm-hmm. Gary decided we went to different medical schools. We were roommates in college, but I remember when he told me he was going to be a psychiatrist, I said, "What is wrong with you, man?" Now, this was before I saw the light. So even then, this was, maybe a few months before I decided. But I said, you want to do that? And so anyway, so eventually I realized that I was drawn there. And so I think for me, psychiatry meant really delving deeply into people. And when I did my training, we had medications and so forth, but it was still kind of a talking therapy approach. Mm-hmm. And I idealized psychoanalysis, so I came to Washington and did psychoanalytic training at the Washington Psychoanalytic Institute, and I've been on the faculty there. And it was very exciting, challenging. I really, and I bet you found it that way too. And so I just loved it. I felt as if I were learning something very profound about human beings. And, it's very easy to be critical about Freud because he got a lot of ideas wrong, but he got some fundamental things right about resistance, repetition, unconscious mental life. Anyway, so I love my training, and I worked as a psychoanalyst, did a lot of psychotherapy, but eventually I realized that there were some people whom I couldn't help or couldn't be helped as much as I wanted. Mm-hmm. And I didn't quite understand why. I had some burgeoning notion that the brain was important, but I didn't even know, what do I do about that? Yeah, the brain's important, but people weren't doing too much with the brain. So what do you do about it?
Yeah.
And so I had an opportunity in 2007. Daniel Lehman did a week-long seminar here in Reston, Virginia, where I work now. And so I had the opportunity to spend a week with him, and I wasn't going to do it because it was a couple weeks before Christmas, and I thought, I'd read Daniel Lehman's book. What am I going to learn? I'm going to miss a week of work and all of that. But I decided to do it, and I realized that what Daniel was doing was, I thought it was a key missing piece for me, that he really was developing a way or had developed a way to look at the brain, and that's something that I needed. So one thing led to another, and during that week, he offered me a position here part-time in the clinic, and I had a full private practice, but I wanted to learn more and immerse myself in this brain imaging approach and learn more about the brain. So started working here part-time, and then they needed more help, and I increased my hours, and one thing led to another. And so about 8 years ago, I guess it is now, I closed my private practice with a lot of trepidation and started here full time. So let me say a little bit more about my evolution here. So, going from somebody who was a psychoanalyst to somebody who's really thinking about the brain. And I don't view it as either or. It's not a dichotomy for me. Right. I like to think about it in terms of how one thing, you think about the electron in physics. The electron is a particle, but it's a wave, and I think we need both points of view. So we need an understanding of intrapsychic life, but we also need an understanding of how the brain works, and I think you need both. But to speak more specifically to some of the cases that I had difficulty with, there was a patient who, in Reclaim Your Brain, I call him Bill, and I talk about him in the beginning of the book. And he was a student at Yale, really bright guy. And so he was a student at Yale. He had these recurrent severe depressions, really deep depressions. And when he was at Yale, he had a very serious suicide attempt, took a lot of medication, a lot of liquor, and it's only because his roommate came back and found him unconscious that the ambulance was called and he was saved. So he went to the hospital and they pumped his stomach, and he took a semester off, and he lived in this area here. So he came, his parents brought him back, and they brought him to see me, and I saw him twice a week, and I tried different antidepressant medications, and I was doing some uncovering psychotherapy and cognitive behavioral therapy, and he improved a little bit, but not much. And I couldn't understand why. It's one of those things. Why wasn't he getting better? So around that time, I had started working part-time at Amen Clinic. So I said to Bill and his folks, as we were kind of taking stock that he had limited improvements despite my best efforts, I said, I've started working at Amen Clinic part-time, and they've got this brain scanning approach. And I think it might not be a bad idea for you to do some, if you go there and have the brain scan. Yep. So we discussed it. He agreed, and he went to Amen Clinic, and he had his brain scanned. And what I found was he had rather significant left temporal lobe damage, and nobody had known. And as I know Chuck, the left temporal lobe is involved in mood and anxiety regulation, and when you have damage to the left temporal area specifically, there's often a kind of simmering negativity or even rage. He didn't have the rage, but he had this simmering negativity that just couldn't be touched. So nobody knew that he had this. There were, really no other indication that he had it. And with this new information, then I questioned him and his parents. How might he have injured the left temporal lobe? And I learned that he had played a lot of soccer that had really never come out. So with the new information, I put him on Lamictal, which is a medicine that really helps temporal lobe functioning. And that was the key, so to speak. He gradually improved. Then the psychotherapy we were doing worked better. And by the next semester, he was, excuse me, close to 100%, and he returned to Yale, graduated, and became an attorney, and has done very well. So this was really convincing for me. I think there's an Eastern saying, when the student is ready, the teacher appears. So I suspect, in some ways he was my teacher, or the case was my teacher, because I was ready to see that. So it's not that you never talk to patients. It's not that their own subjective experience is not important, but we do need to pay attention to the brain. And I've learned a lot more things, not only the brain, but thyroid and infections. And there's a whole myriad of things that you have to pay attention to. So I was broadened. I'll just say that, and maybe I'll pause here.
Well, Joe, it's so interesting how parallel our lives run. That particular Eastern phrase is one that I've enjoyed for many years, and I modified it a little bit because I found myself frustrated with teachers. And so my redaction thereof is, when the student is ready, the lesson appears. So it depersonalizes it a little bit, because if you're alert to the environment, you can catch it from anything. And a person, I've had some wonderful teachers, and I appreciate those experiences, and I'm not diminishing those experiences at all when I say this, but I think the mindset is the reality is the reality, and when we actually face the reality of the moment, it can either be transformational, or we can get lost in denial and just keep on swimming down the same path. Right.
No, I agree with you. And I think, some of my teachers have been wonderful, some less so. Most have been well-intended. But when I was in analytic training, for example, some of the more senior teachers did not believe in ADD. And I sort of say believe in quotes, as if it's a matter of faith. It's like, is there some evidence to support that conception or not? It's not, but that's the way psychoanalysis was, that it was kind of a belief, and that's the way they thought about things.
So since we're on that subject, I'll share this thing from my book, New ADHD Medication Rules. I brought up the Freud paper, Those Wrecked by Success.
Right,
I love that paper. Because what it does is it codifies an individual who has come up to a different level of reality and is unable to handle it. And really what we see with people who have compromised executive function, they can't handle that new reality because of the multiplicity of new variants and variables, and they crash and they have to leave. So Freud, in post-Victorian Vienna, just didn't have an idea of executive function. No fault to him. It's just we've come a long way, and that's
we've come a long way. We've come a long way. Interesting with executive function. Another case that I struggled with was I tried to treat, and this was really before I was easily able to pick up ADD, but I tried to treat through traditional psychoanalysis somebody who had inattentive ADD. And so not hyperactive, but inattentive. So this individual lay down on the couch, tried to free associate, did his best, but his free associations would never cohere into that unconscious red thread that we talk about, which is the unconscious links. And so it's really something. I don't think anybody's ever talked about that, but he wasn't psychotic, but he would talk but you could never put it together in your mind and weave it together in something that was meanful. It took me a long time to figure that out. It took me a long time to figure that out.
It sounds like a terrible experience.
Well, it was frustrating for him. I think it was frustrating for me. And, of course, you wonder, why is this not working? And there's some tendency to be accusatory. In psychoanalysis, there's a long tradition of analysts struggling in silence with their, loving wishes or aggressive wishes. For decades, they all thought that they were the only one with these feelings of wanting to have sex with a patient or love a patient or attack a patient, and they all thought it was an indication that they were not well analyzed. So anyway, I don't want to talk too much about psychoanalysis, but it's something that's been near and dear to my heart, and I still think of myself as a psychoanalyst. I actually do. But I'm not just that. I'm more than that. It's and not just.
Well, I think the brain imaging does really change how a person thinks about the entire process. If a person really understands brain imaging and they have a connection with a human being in the office and they're looking at the brain while they're talking with that human being, it completely switches you over to a much more evidence-based.
I think so. I think so. It's so much more. First of all, as a clinician, having the brain imaging data gives me conviction to recommend a little more strongly what I think might be helpful. For example, with the case of Bill. Now, I was a little bit equivocal with him because I was new in this stuff, but. When I see more cases like him, I can say with conviction, your left temporal lobe is not doing well, or your prefrontal cortex. Say, most people I see like you respond to this or that, and it's not just meds. But there's, a lot of what we do, I think, with the information from brain imaging is reframing development. And that's kind of what CBT is, but I think we do it in a more nuanced way. There's a no wonder you feel bad about yourself, or no wonder you struggled in school, given what we now understand about your executive functioning, your prefrontal cortex. Or no wonder you had unstable moods. It's not you're defective, but your brain hasn't helped you so much.
Quite so.
Yeah.
I'm getting a little echo back with yours because I think the sound is coming up in your office. So.
Okay.
Yeah. So
how is it now? I can turn down my speaker. Okay. Yeah.
So what I was just going to say about that is that, to put it in colloquial terms, individuals get stuck, and for a long period of time, we always thought stuckness in development was strictly psychological.
Right.
And what you're saying is it can be psychological, of course, that is reasonable, but then these biological contributory factors really are worthy of some exploration if we're going to do a thorough job.
That's right. And it's almost always nature and nurture. But for far too long, nurture was emphasized, and our field has done some horrible things to parents with refrigerator mother ideas for autism and double bind theories for schizophrenia. I mean, imagine that. Imagine you have a child who's autistic or, autistic spectrum, Asperger. You already feel bad. And you naturally, I think you have kids, I have kids, you naturally search yourself when your kids have any kind of struggles. But imagine when the whole professional field generates this cockamamie theory, and geez, I mean, it's unbelievable.
I think that this is a little bit of field, and I want to hear more about you. But I think one of the things that's happened is because of that Freudian foundation, that kind of quintessential passivity. That we're going to sit back and we're going to see what your internal problem is. We're not going to actively pursue it. We're not going to chase it.
Right.
Because we really don't know what to chase. So we're just going to let it come from you. And we have a passivity is only superseded by our willingness to take shots at things we don't know with medication.
Yep.
So what happens is we don't know what's going on, but here's a good guess. Let me take a shot at that.
Right. Yeah.
Instead of really knowing what the heck is going on. It's the real reason we're doing these meetings in Core Brain Journal and talking to people like you, because you have that real experience of seeing individuals with real biologic imbalances that are visible and plainly workable.
Right. And exactly. And that's the advantage, or one of the advantages of doing the scans, is you see what area or areas of the brain aren't functioning so well. And when you see it, when you see where it is, you have a better chance of hitting the target with your intervention. And the interventions can be medication, sometimes nutritional supplements, hyperbaric oxygen, neurofeedback, targeted psychotherapy, not to mention dietary changes, laboratory analysis, et cetera, et cetera, et cetera. So if you can't see a target, you might hit it by chance. But, it's like going out on a very dark night into your backyard, putting on a blindfold, spinning around, and then shooting off a shotgun. You may hit the target, but odds are you're gonna hurt something else rather than
shooting geese at night. Honk, bang,
Yeah.
It's up there somewhere. Well, listen, let me ask you this, because you have a personal experience with Lyme disease. And I think this is another area that does bear some important next steps in terms of observation and data gathering and measurement. Could you tell us a little bit about your personal experience with Lyme and what your thoughts are about that?
Oh my goodness, we could talk about this for hours, but I won't. But my daughter Elizabeth, who is now 29. Had a very bad case of mono when she was about 12. And in retrospect, she never really fully recovered. And since that time, she had light sensitivity, headaches, irritability, brain fog, memory impairment. And we went around, we didn't know what the heck was going on. And we went from pediatric neurologist to neuro-ophthalmologist to headache specialist. And of course, when nobody could figure out what was wrong, eventually they said, she needs to see a psychiatrist. So here I am, a psychiatrist, and my wife's a nurse, but you do anything to help your kid. So we took her to a psychiatrist and saw a couple good people, but they couldn't figure out what was going on either. And eventually, about 5-6 years ago, because I was seeing quite a few patients in my own practice here at the clinic, at Amen Clinics, with Lyme disease, it kind of struck me that, these patients with Lyme remind me of my daughter Elizabeth. So I called a Lyme specialist nearby and asked him to see her, and he consented graciously. And it turns out she's had Borrelia, which is Lyme, and Bartonella and Babesia, which are two of the co-infections, probably some viruses too. So she's, when you have Lyme disease for a long time, it's not easy to kind of take care of. If you catch it right away, meaning within a day or two of getting bitten, maybe you can fully eradicate it, but most people have it chronically. But I've learned then through my own daughter, and I don't treat her, I just happen to, hear about what's going on in her treatment. But I've seen hundreds and hundreds of patients over the years now with Lyme disease, and probably have seen more SPECT scans of individuals with Lyme than anybody else in the world. Now, lest you think I'm tooting my own horn, very few people have actually looked at this. So when only 2 or 3 people are doing something, it's not hard to be a world expert, That's
okay. I'm sure somebody out there is going to have a problem with talking, but listen, I think it's great that you share that, because that's an advantage to being there, having that level of inquiry and investigation, because you see it if you look for it.
Yeah, it's really something. It's almost a kind of blindness that if you don't think about something, you won't see it. And now I don't even know 15 years ago if I had heard of Lyme disease. I can't remember that anybody talked about it in medical school with me. Maybe they did and I forgot it. It wouldn't be the only thing I forgot. But But it's I have learned that Lyme is epidemic up and down the East Coast, in the Midwest, certainly up and down the West Coast, probably throughout the whole U.S. Also, other countries, Europe, France. It's quite common in France, Asia, South America. So it's all over. They found the genome of the Lyme organism in Otzi, this, I don't know if you heard about this guy, this Iceman. He was found in the Alps. So they've recovered 2/3 of the Lyme genome from him.
That's right. I didn't realize that.
And he had tattoos on his kneecaps, or in the skin over his kneecaps.
Yes,
And the thinking is he may well have had Lyme that often causes pain in the joints, and the tattoos may well have been a way to try to combat the knee pain, in a primitive way. But Lyme can mimic, and when I talk about Lyme, I'm not just talking about Borrelia, which is the Lyme organism, but Babesia, Bartonella, Ehrlichia, Anaplasmosis, Rocky Mountain spotted fever, all the so-called co-infections. So Lyme can mimic or cause any kind of medical, neurological, psychiatric issues. My good friend Gary, whom we mentioned earlier, nearly died because he had Lyme, and he ended up with second-degree heart block.
I didn't
that was
realize that. By the way, Gary Moak is that's episode 040, just by the by. He was a very interesting guy. I didn't realize that about him.
Yeah, and he that was his only symptom. He's a very healthy guy. I always joke that if there were a nuclear holocaust, it'd be the cockroaches and Gary who would survive because he's so healthy. But he, but he spent a lot of time outside. He has a place in the mountains and really, hikes, climbs in the mountains. So he was bitten, and a second-degree heart block was his only symptom. And they talked about putting in a pacemaker and so forth. Thank God he recovered, but it was really not, he wasn't doing well there for a while, but he's made a complete recovery. So, Lyme, from cardiac issues to brain fog to seizures to, you name it. So one of the maddening things is that Lyme has to be part of the differential diagnosis of virtually anything. So I've had patients who've come in and we've done the scans and they seem to have a bipolar disorder. Yet something's not quite right, and I eventually do some testing. It turns out they have Lyme disease, and you treat the Lyme, and what seemed to be bipolar goes away. Or same thing with ADD, same thing with anxiety, same thing with panic attacks. So I'm not saying that all of those, that those things are only Lyme, certainly not, but you need to think about it. So it seems that the psychiatrist of the future will need to be an infectious disease specialist in a way, which is absolutely bizarre for me. I never, ever would have suspected that.
Yeah, I think parallel to that is the whole immunity issue, because it's directly related to the Lyme situation. So if you take Candida and you take biofilm, which is such an important aspect of Lyme, and you put all those things together, you've got immunity. You've got co-infections, and what's interesting is I often joke that what we're doing is we're running around doing, the brain being the canary in the coal mine. We're running around resuscitating canaries instead of looking for the methane.
You got it. No, you got it. You got it. And you make a very good point. And I think, when I talk about Lyme, I think it can be a little bit misleading when I talk about it, or anybody, because Lyme, what we're finding is, just as you said, it's not just an infection. You always have inflammation. You always have dietary issues. You'll very often have, Candida overgrowth. Virtually everybody I've ever seen with Lyme will have low thyroid, low testosterone, even women. So there's so many things. So there are multiple systems involved. It's not just the infection. And if you think you can help these people just by throwing an antibiotic at them, you're wrong. So I agree with it. It's almost like we're going back and reinventing medicine, from a or looking at people from a functional medicine point of view, which I know you understand well.
Well, I think both of us do. I think the issue is there's an unfortunate dichotomy that exists between functional medicine and traditional. And
Right.
my particular buzzword for the way I approach these things, and I know you do too from speaking
Yeah.
with you, you and I haven't had an in-depth conversation like this, but really comprehensive medicine is what it is.
Right.
I mean,
Right.
because I've seen the functional medicine disparage traditional guys. I've
Yeah.
been traditional meetings where they say those guys are all quacks over there talking about Lyme disease. It doesn't even exist, you know?
Yeah. Yeah.
And yet that's the nature of the beast. If we look comprehensively and indeed scientifically, then
Right.
we can't argue with reality. If it's there in your face, it's
Yeah.
in your face.
Yeah. It's there in your face, but sometimes people have a kind of a blindness, you know.
Yes, quite
It's
so.
like they don't see it. I have a natural curiosity about things, as I know you do too. So that drives me in part. But most of what I do is I want to help people. You know, I'm fascinated by how the brain works and how body systems work. But I will do anything within reason to help somebody, and that's why I'm interested in this stuff. Just saw, an individual this afternoon who's apparently seeing a good primary care doctor, but my patient was, hypothyroid, and the doctor never checked the appropriate thyroid hormones. And even more beyond that, it's like you don't go on the hormones, you go, how's the patient doing? And, it's like, I don't know.
Totally
Don't want to be too negative.
Totally with you, Joe. So we're running a little bit out of time. I've so much enjoyed this conversation. It's a pleasure getting to know you personally.
It's great.
We share some common interests, but it was so much fun listening to your perspective on these different issues. And I think it's just great to find a comrade out there who's on the path, who's really thinking about these things more thoroughly and really spreading the word to our listeners who are curious about these things and what can they do next? Are there other options? So in closing, what would you say, Joe, in terms of where we should go collectively? I mean, that's a big question, but think for a moment from your years of experience, getting deeply into some really uncommon perceptions, brain injury, Lyme disease, and your book is going to spell out a lot of this. We're going to have that book available as a drawing at Core Brain Journal on corebrainjournal.com/058 drawing. So a person can just go in there and enter the drawing, and we'll have that set up for 2 weeks post this publication. But sorry to do that quick plug, but I wanted to make sure we got your book in there. So what would you say would be kind of a closing remark? And it's hard to bring all of this into.
Oh my goodness, yeah.
But what would you say our listeners should really think about when they're going down the road with these topics we've talked about?
Well, I would say we live in a very exciting time because the patients, the people we see and their families, they have access to so much information on the internet, in books and so forth. A lot of it good, some less so, but it's freely available. And it's exciting for me to have my patients come in and know more about a certain thing than I do. Mm-hmm. There's a little bit of a narcissistic blow, but I want to learn, so that's okay. So I don't mind if they know more. I can learn more. And I don't mind if they have questions. But what I would say is, there are different ways to approach these conditions now. It's not just throwing some Lexapro or Abilify at somebody. There are so many things to think about. Patients need to be able to think outside the box, and especially clinicians need to be able to think outside the box. So if they're seeing somebody and they're not getting the benefit they like, they need, they want, then try to find somebody like you or me. Consider a more comprehensive approach, maybe brain imaging, really look potentially for infections, look at thyroid, look at other hormones, look at toxicity, look at brain injury. There's so many things we can look at now, and there's a lot of evidence to support these. So Probably, well, not. Let me get rid of the probably. I think more help is available right now than ever before.
Yes.
And sometimes it requires a bit of boldness, a bit of willingness to see somebody who doesn't think traditionally. But I know lots of people find you, and they travel from all over the country, all over the world to see me, to see you. Same thing for me. So they can find us. They can find people like us, and people can get a lot better, and it's very gratifying to help them on that path.
Well, I appreciate your contributing to this, because this is the kind of thing we're interested in. I mean, basically what we're doing at Core Brain Journal is trying to open that door so that people can think about things more comprehensively. And ours, of course, as you just said, is not the only answer. Our answers are not the only. And many people know a lot more about these things, but I think the thing that's important, just as you referred to, is having the conversation.
Right.
Really taking it down the road further and opening our minds to other possibilities, many of which are in the living in this new biology that we now have the technology to understand. So it's really, really terrific. Thank you so much, Joe, for taking the time. I appreciate it.
You're very welcome, Chuck.
I'm going to invite you publicly right here. I'm putting you on the spot, buddy. I want you to do if you would, please. I know you're a writer, so I would welcome, you're so articulate and so thoughtful. I would welcome a brief article for Core Brain Journal on what you think about the Lyme workup, because I'm sure you stimulated a lot of interest with listeners. And if you did a little article, we'll pop that up. And we'll look into your show notes so a person can say, okay, here's what Dr. Annibali says we should do about working this up.
Okay. Will do. You got my commitment there, buddy.
I appreciate it. So thanks a lot, Joe. You have a great day. Very nice talking to you, man. Thanks for listening to Core Brain Journal. We're working every day behind the scenes to bring you reports that connect research benches with those street trenches. Here we share the complexity of mind science because, as you know, details really do matter. One of the most pervasive, misunderstood challenges is how commonplace medications, like those written for ADHD, are used so regularly without clear guidelines. If you think you'd like more specifics, take a minute to download my 2-page PDF packed with video links and references on the absolute essentials of how to start ADHD medications. They're easily available at corebrainjournal.com/start. Thanks for listening. Do connect and stay tuned. Together we can make a difference.